Thanks, Megan. So welcome everyone to this evening's Doc Talk. We are so excited to have with us Dr. Sucandy. He's going to talk to us about state-of-the-art liver surgery with robotic technology, and we're very, very fortunate to have him. I know that we have, I think, at least a couple of patients or people that have consulted with him in the past. And of course, this is being recorded so we can share it in Town University and help many patients in the years to come as well. So just to tell everyone how this is going to work, if you've not been on one of the Doc Talks before, just remember that you've all been muted, and we're going to let Dr. Sucandy do his presentation and talk and educate us. And if you have questions as the presentation goes along, please put those in the chat. So in the chat feature is where you will put your questions. At the end of the presentation, we will go over the questions that are in the chat. So again, I'm going to turn it over to you, Dr. Sucandy. Thank you so much for being here with us and for doing this presentation. I know this is going to help so many of our patients now and in the future. So I give it to you.
Thank you. Thank you. So thank you for the honor and privilege to be part of this program. And I feel when I heard about Town, I said, wow, the name is kind of interesting. It's a Town. But, immediately I realized that there are a lot of patients who have colon cancer with liver metastasis, and they are kind of sometimes in a difficult situation where the liver tumor are many and they are significant, and it is a complex disease to take care of. I am privileged to talk about evolution of surgical treatment for stage 4 colon cancer with liver metastasis. And specifically, I want to raise the issue about robotic liver surgery, which I feel like it is important to know because many people actually don't know this. I am a chief of HPB surgery at Advent Health in Tampa. I've been in practice for almost 10 years. I train in Pittsburgh and many places. And we do this on a routine basis. I do liver surgery actually every day. And since 2016, we have performed 1,000 liver surgery, and approximately 600 of them are actually minimally invasively. So you can see how we try to really improve and bring the best surgical option for patients with colon cancer with liver metastasis. So the outline of my talk will be 5 items. One is mechanism and how the colorectal metastasis occur. The second is how the treatment changes since 1960 to today. The rise of minimally invasive surgery. What are the trials that compare minimally invasive versus traditional open resection for liver? And where are we going in the future? And what is the new technology there? This is just opening slides. Colon cancer is the 3rd most common cancer in the United States. 50% of colon cancer result in liver metastasis, either synchronous, meaning that they are diagnosed within the same 6 months of the primary cancer, or metachronous, where they are diagnosed at a different time beyond 6 months of primary diagnosis. The fortunate thing is the liver is the only site of metastasis in about 40% of patients. It means 40% of patients, they only have liver disease. Now, the standard of treatment is to try to remove all the liver tumor with the goal of achieving R0 margins. Now, when the patient comes to the office, they ask me, doctor, should I get this done or not? The answer is in this red box. Unresectable patient has poor outcomes with 5-year survival, OS is overall survival, of 0 to 10%. Resectable patient, however, have significantly better outcome with 5 years of overall survival of 60%. So if the patient come with 1, 2, 3, 4, 5 liver tumors, and they ask, doctor, should I have liver surgery? The answer is, in 5 years, do you want to live or you don't want to live? Because if you have this liver clean up, in 5 years, 60% of patients will still alive. If you don't, the statistic says only 0 to 10%. That's kind of big difference. This is why it became a standard of care in the United States. So the mechanism of colorectal liver metastasis, many papers discuss about this, but basically this is the bottom line. The bottom line is the cell from the colon cancer, rectal cancer, they shed into the small or large bowel venous system. So those tumor cells get carried to the liver. Liver act like a filter for the cells. So those tumors, they got stuck in the filter and they grow in the filter. So in some patients, those tumor, they stay in the liver for a long time. They don't grow, but in some patients, immediately they hit the liver, they start proliferating or start making so many tumors. But that's how the tumor from the colon and rectum get to the liver. Now, there have been many papers that discuss about the natural history of hepatic metastasis. Natural history means there's a patient who come with the colorectal metastasis and they watch them, how they do if no treatment is given. So if you can see the diagram on the left-hand side, in the x-axis is years. It means at the beginning, everybody alive, 100%, but in 5 years, you can see here, barely anyone survived without treatment. Now, in 1983, 40 years ago, the 3-year survival for solitary, it means single liver metastasis, is 21%. If they have multiple metastases in one side of the liver, the survival dropped down to 6%. So the number of tumor does have implication from prognosis standpoint, in terms of the survival in the 3 to 5 years. Now, this is a slide that I want us to all look at. The dotted line on top is the patient who have resection with clean margin and then no evidence of disease. The bottom line, the red arrow, is the patient who have no resection for whatever reason. So you can see here at 5 years, I hope you can see the pointer, 5 years, the survival is essentially like 1%. While here, the survival is about 35 to 40%. This is in 1983. Many things have changed since 1983, and the survival has increased significantly. This is another paper from René Adam from Paris, showing a comparison between resected patient versus non-resected patient. This is at 10 years. This is beyond 5 years. This is 10 years. And you can see here, patients who are resected aggressively and leave with no tumor, in 5 years, a quarter of patients are actually cured. I know it's hard to believe, but 25% of patients are actually cured in 10 years. So the take-home message is resectable patients should undergo liver resection due to the increased survival. The comparison of surgery versus others. A lot of oncologists has difficulty understanding this, especially when I came to Tampa. I found out a lot of oncologists actually don't know what the surgical treatment should be, and they keep the patient with chemotherapy forever. I've operated a patient who have chemotherapy for 7 years, to a point where the patient is like, "Oh, doctor, I've tried all chemotherapy," and they have circled me with like 3 times because they're running out of chemotherapy. You can imagine 7 years. So surgery plus chemotherapy give you the first line on top. They have the best survival. You see chemotherapy alone, this is the second line, much inferior survival. The third line is do nothing. It's called basic supportive treatment. Barely the patient live a year plus. With chemotherapy only, 2.5 years. With surgery, they live much longer with a 5-year survival now reaching 70%. Now, I want to talk about how the treatment has evolved in the last 40 years. The treatment has changed dramatically. Why? The surgical treatment for liver and extrahepatic disease, meaning that the tumor outside the liver, is now more aggressive. The systemic chemotherapy has improved as well. It's getting better. Now we have immunotherapy. All the stage 4 patients get genetic testing by definition, is automatic in our program. They all get foundation analysis and PD-L1 inhibitor testing. The outcome of surgical liver resection also improved. How is improved? In the 1970 to 1980, to split the liver in half and remove half of the liver, it leads to about 20% mortality. It means 5 patients, 1 died from this. Today, the mortality of well-done operation to split the liver is less than 1%. So you can see here the technology has improved, the understanding of the liver surgery has improved, equipment has improved. The liver surgery now is more casual. It's no longer something that is scary, something that is like the end of the world. No, this is a big surgery, yes, but it is done widely. It can be done safely with very little mortality. Now, a little history about this. In 1976, the surgical treatment started with a minor liver resection. At that time, the surgeon were a bit unsure of how to do big liver surgery. So what they do is they do a little bit of surgery, just kind of, taking 5% of the liver, call it. And those tumors were on the edges of the liver, not in the central part of the liver. Technically, it is much easier to remove tumors that is smaller. It is much easier to remove the tumor that is on the edge of the liver. Now, they study the patient as well. Solitary lesion, patient with a single tumor in the liver. Some patients actually live more than 10 years. You see here, 8 patients live more than 10 years out of 60 patients. Now, a patient with a multiple lesion, a lot of lesions, they all died before 5 years. So at that time, the conclusion was you can operate on the patient as long as it's minor and as long as a single lesion. But remember, this is 1976 when the chemo was not good, surgery was not good. Now, fast forward in 1980. So this is 6 years later. Another paper on annals of surgery that says, well, you can actually do major liver resection and at least 20 to 30% of patients will gain benefit, survival benefit from this. You can see the picture here. The tumor is big on the right side. In order to remove this, you have to split the liver and remove the right side. And even with this operation, at least 20 to 30% of patients were able to gain survival benefit. And remember, this is 1980. This is when I was 1 year old. Fast forward 2000. In 2000, people started to offer patients with multiple bilobar hepatic metastasis. They have tumor here, 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 both sides of the liver. When I came to Tampa first time in 2016, a lot of oncologists said, well, if the tumor is both sides, it's game over. The answer is not. This is actually understanding from 1980. So even in 2000, resection of bilobar, both sides of the liver, bring results similar to a survival for a simple metastasis, single metastasis. At that time, the survival 5 years is 37%. So you can see on the previous slide, it was 25. It's slowly rising up to 37 now. At that time, extended resection was avoided, and also concomitant resection of the colon or rectal primary was also avoided because the technology was not very good, and it brought a higher mortality rate. So at that time, it was avoided. Now, it's no longer avoided. It's actually recommended as long as it's safe. So the bottom line at that time was resection of multiple tumor, both sides, resulted in improved survival. Fast forward 5 years later, 2005. What if the patient have liver metastasis resected today? How about in 3 years, if the patient have another tumor, what should we do about it? Should we let the patient go? Should we do nothing? Put them on chemotherapy forever? Radiate them? What do we do? So the answer is the patient needs a repeat liver resection as long as the patient is able to undergo liver resection. Why? Because it further improves survival with lower and lower operative risk. Even with redo resection, it is harder to do. It is higher potential complication a little bit, but in the right hand, it can be done safely with low operative risk, and this will bring a lot of survival for the patient. This has been published extensively. Now, how about if the patient have liver metastasis and lung metastasis? This is something that also is an issue in the medical oncology literature. You know, they will say, well, liver metastasis is bad enough. How about the lung metastasis? But also, that is an old school. Look at this paper here. The patient with synchronous metastasis of lung and liver, when they get resected, the survival is much better than the patient who are not resected. You see the two curves here. So the upper one is resection, lower one is non-resection. This is for synchronous metastasis. It means they're diagnosed together. If they are not diagnosed together, it means they come, a year later, for example. That lesion in the lung should be resected also. Why? Because look at this curve, also different. Patients got resected, they live a lot longer, improve survival. Another paper from America that basically also have the same conclusion: surgical resection of both liver, hepatic, and pulmonary metastasis is associated with prolonged survival in selected patients. Obviously, you cannot offer them to everyone, but there are a lot of patients who can benefit from this. The most common location of colorectal metastasis is liver. The second most common location is lung. So those are number one and number two. And you can see here overall survival after resection of the other metastasis, even in 10 years. 10 years is a long time. About 19% of patients still alive. And there is no way to achieve this without resection. No way. Now, we can see the evolution of treatment. The surgeon become more aggressive. The patient can live longer. Chemo is getting better. Everything worked for the patient. So now the question is, where is the limit? Is there any limit? Yes, there's a limit. So what is the limit? One is the general health and performance status of the patient. The patient has to be acceptable risk for surgery. How is the liver working? Any fatty liver disease, any cirrhosis, how much chemo the patient has gotten. As we know, the chemo also give a negative impact for the liver function. So sometimes the patient got so much chemo to a point where the liver is so damaged, it is difficult to offer the patient a big surgery because the quality of the liver is poor. We also need to know, did the patient have a liver resection in the past? Because that can affect the planning for the future. Did the patient get Y90? Did they get hepatic artery pump? Did they get chemoembolization? They all have to be known, take into consideration, because overall, this kind of treatment affect the liver function to some extent. Now the question is, how much liver to live with the patient to avoid not having enough liver? It's called postoperative liver insufficiency, or also called liver failure. How much is liver enough to leave behind? Now, in our program, and also in all the centers that perform serious liver surgery, this needs to be studied before surgery. The surgeon cannot just, I just eyeball it and I know. No, it's not. It's actually not true. You actually have to spend some time to study the liver to see, if I do this, I remove how much percent of the liver and how many percent I leave behind. So it is from the CAT scan and MRI. It is entered into a software that can actually reconstruct the liver in a 3D fashion. And this can give us a measurement milliliter by milliliter of each segment of the liver to know how much to take out and how much to leave behind. There's also called functional test. Is a test to see how much the overall liver function is. The patient who drink a lot, cirrhosis, for example, patient who have a lot of chemotherapy, they may have a big liver, but it may not have the same function as the small liver, but healthy. So you can imagine like a big obese patient, right? They are 200 pounds, but they are not necessarily stronger when we compare the patient who is 70 pounds, or not 70 pounds, like 100 pounds, but it's all muscle. You see, so there's a difference between liver to liver, and this is something that oftentimes we study in order to get a true measurement of the liver function before we put them through a major liver surgery. So this is something that we do. For example, I want to show you, this is a routine procedure in our center, actually. So you can see here, we reconstructed the liver, and you can see, let's use this, for example. So the red structure is the tumor. It's deep inside the liver, and we say, okay, if I'm going to split the liver, I'm going to remove this much, and I'm going to keep this much. All the lines on the left hand side here, it give me how big is the liver on this side, how big is the liver on this side. So I know if I cut here, I remove, for example, 40%, and I leave 60%. And similar to other diagram here, you can see different type of resections. And the software also help us with the tumor localization. The green is the bile duct, because we need to plan this better in order for the liver to be successful, to be safe. They're able to grow back. You have to keep the pipe in, pipe out, and the bile duct. It is very common for the patient to ask me, "Oh, doctor, the liver grow back?" The answer is yes, but there are factors that you need to meet in order for the liver to grow back. The liver has to have enough fuel in, exhaust pipe out, and the bile duct. Even if the liver is big, but it is missing one of the component, the growing back is not going to happen. And in fact, the liver can quit and kill the patient. So yes, it can regenerate, but it has to be done well. So is extended hepatectomy, meaning that can a big resection justified for liver cancer? This is a very important slide. In the patient with normal liver, it is safe to leave only 20% of the liver. So we can remove 80%. Patient who have chemotherapy, you have to leave 30%. You can only take out 70%. Patient with liver cirrhosis, you have to leave at least 40%. It means you can see here, as the liver gets sicker, the less part of the liver can be removed, because otherwise the patient can get into liver failure, and liver failure is a big reason for mortality, death after surgery. So if the patient comes with liver remnant that is too small, should we say to the patient, "I'm sorry, you have no option," or it is something that we can try to improve? The answer is there are few things that we can do to improve the small remnant liver to a big one. How to do it? One, this is a very common way, it's called portal vein embolization, meaning that we block of the blood supply to one side of the liver, and this will induce a growth of the other side of the liver. Number two is we combine the portal vein embolization with hepatic vein embolization. It means we close the blood inflow to one side and also the outflow on that side. So it is more aggressive closure of the blood vessel on the resected side, on the part that's going to be resected, in order to induce more hypertrophy of the remnant liver. The other way to do it is to do two-stage. It means if the patient have 10 tumors, 5 on the left, 5 on the right, to do 10 altogether, sometimes it's too major. So what you do 5 first, one side, have the patient recover. 2 months later, go and do the other side and clean everything. And then the last way of doing this is called ALPS procedure. It is something that not very common in the US. However, in our center, we obviously offer this, even robotic ALPS procedure. We have done many of this. Just because we have a lot of patients with difficult tumors and small liver remnant, and they have been seen by many surgeons in the past. So it is something that can be an option. It has to be done carefully. The calculation has to be done carefully, and the surgeon has to have experience with major liver surgery like this. So this is just the example, the picture of this. You can see here if the patient have a 4 tumor, for example, if we close this portal vein here, the blood will be shunted to the other side. This will make the other side larger, and we wait for about 6 weeks or so, and we go back and we're gonna take out this. Now the remnant liver is now huge, and it works well. With the ALPS procedure, we have the benefit of doing a split of the liver with closure of the blood vessel at the first operation. And also, if the patient have a tumor on the other side, this can be wedged out at the first operation. The second operation, the surgeon come and remove this part altogether. And both of this actually can be done minimally invasively in our program, done robotically, both the first stage and the second stage of ALPS can be done robotically. The initial description of ALPS was open for both stages. This is just a picture of how much liver growth that needs to be done, needs to be achieved to avoid liver failure. We are trying to get the liver growth at least 2% per week. So if the liver is growing more than 2% a week, at least 2% a week, it is going to be safe to do a major liver resection. So this calculation of this. This is what I said about the double embolization called PVE plus HVE. So the radiologist actually go in with the catheter, close the vessels. The tumor is on this side, right? So we're gonna take out the right side. So the blood vessel to the right side is being closed here, occluded here, and also the outflow is also being occluded. This will induce a lot more hypertrophy versus just inflow being occluded. And this is two diagram that I said before. When you occlude both vessels, the growth is much faster versus one vessel only. This is some modification of ALPS. You know, we started our ALPS program maybe about 6 years ago. And we have modified how we do it over the years. We try to do it minimal invasive, both stages. And also we try to be less invasive on the first stage, which make the second stage easier and down the line. So there's a bit nuance of how to do this. And I don't want to go into detail here, but the center has to be able to explain to you what's expected after the first stage and what's expected after the second stage. So now shifting toward minimally invasive surgery. You can see here minimally invasive surgery started with the general surgery and then go into pancreatic surgery and finally go to the robotic liver surgery as the most modern minimal invasive liver section. This is the two pictures comparing open operation versus robotic. This is open operation. The abdomen is opened widely. The retractor is used, while minimal invasive, you can see this is the trocar, usually 5 or 6 trocar. This is a green port. This is where the liver is pulled out. The patient always asks me, doctor, how can you pull the liver through a small incision? And actually, there's a way to do it because the specimen is placed in the bag, and we actually pull the bag with the liver in it through the small incision. When the patient is anesthetized, the abdominal wall is so relaxed, we sometimes extended the incision a little bit, but with relaxation, we're able to remove big specimen, even the right lobe, through the small incisions there. The question is, why minimally invasive surgery? Is it better or is it easier? The answer is minimally invasive surgery is better for the patient, harder for the surgeon, actually. Now, the question is why the surgeon wants to do it? Because it's harder for them. Yeah, because we do it because we like it when it's better for the patient. That's why we do it. Many publications have compared minimal invasive versus open liver section. The minimal invasive leads to less blood loss because you're losing less blood. There's less blood transfusion. The patient can drink on the same day. Less pain medication requirements, shorter length of stay in the hospital. lower wound complication, infections, incision open up, hernia, yada, 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 cosmesis, better. And it bring a comparable or potentially better oncological outcomes. Now, we used to be debating about this topic, whether minimal invasive lead to inferior outcome. You can see there's two lines here. So the outcome of minimal invasive versus open in 5 years are similar. So at least minimal invasive surgery does not compromise the outcome of oncological treatment of this colon cancer with liver metastasis. So we now quit debating this because every surgeon knows that minimal invasive surgery does not lead to inferior oncological outcomes. We are not missing tumors with minimal invasive. Why? Because the camera gives you 20% magnification. So it's actually easier to see the tumor on the camera versus naked eyes. There's so many papers that have been published about this. And the criticism was, well, those papers are not randomized. It is just a publication from one center and the other centers. We need a randomized trial where the patient is blinded, the surgeon is blinded. It means the patient, when they go to surgery, they don't know whether they're going to get minimally invasive or open. And the first randomized trial was actually started in 2015 in Oslo, comparing open versus laparoscopic for colorectal metastasis. The outcome was published 3 years later in 2018 on Annals of Surgery. These two guys are my friend. So the outcome is the minimal invasive surgery, liver surgery, leads to lower 30-day complication rate, shorter hospital stay, and less pain medication requirements. Similar OR time, similar blood loss. And they also follow the survival at 60 months. 60 months is meaning for 5 years. Look at the survival are equal. The same as recurrence-free survival is actually a bit better laparoscopically. But the bottom line is oncological outcome is not inferior with minimal invasive surgery. Now, as soon as the first trial is done, the second trial came. This is 2019. This is a year later after the first trial. This is from Spain that also compare open versus minimal invasive surgery. And the outcome is well, almost similar. The minimal invasive surgery bring lower morbidity, shorter hospital stay with similar OR time, blood loss, transfusion rate, mortality, and similar 3, 5, and 7-year disease-free and overall survival. So you can see here if a patient able to get minimal invasive surgery, that is what they should get. Unless it cannot be done minimal invasively, it needs to be done open, then they need to be done open. Shifting gears to what is the future of liver surgery? Technology is getting better. We have more modern robotic surgical system. You can see here. This is how the equipment for liver surgery now. The robotic liver surgery is now expanding for a bile duct cancer surgery, benign biliary surgery. If the surgeon needs to put together the blood vessel, used to be the surgeon is very scared doing this. So the patient that has tumor close to the blood vessel, they do it open because the technical skill is not there. So today, however, in our program, at least, we started to do vascular surgery robotically. We don't have to open the patient for portal vein reconstructions or hepatic vein resections. And it is something that we continue to push the envelope forward to make this operation as safe as possible and more minimal invasive, which enable the patient to go back on systemic chemo quicker. Now the 3D is coming, the artificial intelligence is coming, more modern technology for liver surgery. So this is just a few papers we published in collaboration with the European Centers for biliary surgery. We have also actually developed this, what we call Tampa, because we live in Tampa difficulty score, a scoring system for difficulty of robotic liver surgery. We are a training center for robotic liver surgery for US and the world. So a lot of surgeons come to the center in Tampa to learn how to do liver surgery from me. And we designed this scoring system to see how difficult the liver surgery will be. So then the surgeon can get prepared. Am I ready to undertake the surgery, or I have to have my partner or my senior surgeon to help me doing this in order to arrive in a best outcome and safe outcome. So then we developed this. You can actually check this on the website, and you can come with a score. The higher the score, the harder the liver surgery will be. The lower the score, the easier. So this is a website that is alive. You can play with that actually. It is useful for surgeons. We published this on the Journal of GI Surgery uh, um, 2 months ago. So you can see here, this is how the blood vessel being cut and put together robotically. We used to have to open the patient for this. Now we can do this with robotic surgery. The conclusion is liver surgery for metastasis is safe. It can be done aggressively, and it should be done aggressively. However, you need to find an experienced surgeon for this, because not all the liver surgery are straightforward. Some of them needs a two-stage, some of them needs a vascular reconstruction, some of them need bile duct reconstruction. Those are not easy. Those are much harder than doing a wedge resection. And if possible, always ask for a minimally invasive liver surgery unless technically not feasible. Now, there are cases that needs to be done open. For example, in our center, if the patient have more than 8 tumors throughout the liver, we give a consideration to do it open. Can we done minimally invasively? The answer is yes, we can, but it is not practical because the operation can take 6-7 hours to do. Versus open, it may take 3 hours to do. So we also take into consideration the time on the operating table. So we try to determine the difficulty of all the aspect, not just the cutting of the liver, but the timing of the operation, how much time on the operating table, how old the patient, and how complex the operation will be. The best long-term outcome come from multimodality treatment, where the surgeon will work together with the radiologist, IR, medical oncologist, radiation oncologist, and other people. Now, I want to show you a video clip. So then you guys know how the liver surgery robotic looks like. So the video on the left is a resection of the liver tumor after a local recurrence from ablation. We know that ablation has about 6% of recurrence in this patient. He's only 52 years old. He had colon cancer liver metastasis on the back of the liver, get ablated somewhere else, and he came to our center with single tumor recurrence. And you can see here the cancer is on the upper side, the ablation on the lower side. And we decided that this needs to be cut out. The interesting part is the tumor actually grew to the diaphragm. So we have to cut out the diaphragm as well. So this is the tumor, we're gonna cut it this way. The picture on the right side, let me pause on the right side, so otherwise it's too confusing. So this is how the surgery is done with the robotic. You can see the scissors, you can see the grasper, you can put a stitch on it, we can pull on it, we can dissect the blood vessels that bring blood to the liver. It is almost like open surgery, except it is done with small incisions. This patient have 5 ports, and each of the ports is about 8 millimeter in size. 8 millimeters is less than a centimeter. And you can see we can tie the blood vessel to the liver to be resected. and we can really clean up and see the structure that we need to see. This maneuvers takes some experience, some training to do it. We encourage the surgeons to learn how to do this in order to gain the benefit for the patient. Um, it is important to apply this is called ICG. It is a technology where we inject into the bloodstream to see the perfusion of the liver, and also to help us to see where is the cutting line for this case. You can see here we have a scissors that can deliver energy, and you see here on the diaphragm there is something that is stuck. That is the cancer that is stuck to the diaphragm. A big vessel being skeletonized. This is a stapling device that actually can seal both sides and cut in the middle. It is a question that I hear from the patient a lot. Doctor, how do you cut the liver not bleeding, not bleed? The answer is we have a technology that will help us do that. We can cut in the middle, and the device will seal both sides, so both sides will not bleed. This is an ultrasound. We can see the liver tumor deep in the liver on the ultrasound. You can see here now we're cutting the liver, is bloodless. And we will see the crossing branches, and those branches is clipped. You can see the white stuff there. It's the clip. We place it, we cut in the middle, they don't bleed. And sometimes the clip is not perfect, it bleeds a little bit. We can just put a suture on it and tie it. Many times we tie first and then we cut second. I'm going to start the second video. Now, the second video is actually ALPS procedure, except it is more than ALPS. Why? Because the patient have a single metastasis in the left adrenal gland. So Betsy asked me to talk about what if the patient have tumor outside the liver. Obviously, the patient need to be selected, but both videos shows you the tumor outside the liver. One is in the diaphragm, one is in the right adrenal. So the video on the right lower quadrant, right side, I am taking down the blood supply to the adrenal gland that got cancer in it. So you can see here the clip is done, cuts, and in about 10 seconds, the adrenal will come out. You see the adrenal gland got cancer in there, it's removed. The left video now is going through the deep liver. We are splitting the liver, inside the liver. This is how this look like. It's a little bit of oozing here and there. This is not a big deal. On the right side, I'm trying to find the portal vein and the artery because I need to ligate this as a first stage of our procedure. The gallbladder is taken out, the first stage, obviously. And you can see here, we set this operation to be successful or easier for the second stage. The video on the left side move towards the end of the operation. You can see here, we can cut the liver with very little bleeding as long as it's done well. Now, the specimen now is being removed. The last staple was done. Now, the clamp is released. Now, the tumor is stuck to the diaphragm. You can see here the yellow stuff. This is the prior ablation cavity. So I clean up that. I suction out the yellow stuff. As I tried to remove the specimen, I knew that the diaphragm needs to be resected. Now we have resected the diaphragm. You see the lung at the background, and now we're closing the diaphragm. So this is relatively difficult liver surgery. It can be done well. It took about 6 hours to do. It is done minimally invasively. The patient went home 5 days. Now, the video on the right side, now we're going to the second stage of our procedure. We actually combine the second stage with the reversal of the ileostomy. The patient have a temporary ileostomy. Now the volume of the liver increased from 25 to 35%. So you can see here on the second stage, we go back. This is a different instrument for synchroseal, robotically as well. We cut the liver. The liver to be removed is on the right side, on the left screen. You see the vessels being ligated, clipped, divided, safe, no bleeding. The vena cava is at the back there with the robotic instrument. You see here we are creating a tunnel to split the liver. So in this patient, essentially, I remove tumor from both sides of the liver, tumor on the adrenal gland, and tumor in the rectum. And those were done during this out procedure, combining first and second stage. So this is a tumor outside the liver as well, because they're in the adrenal gland, they're outside the liver. This patient is only 40 years old, he's doing well. This case was probably done about maybe a year ago or so. Patient's doing well, no recurrence, enjoying life, 2 kids, and we are very happy to see him. This is the website of mine that you can see if you like to read a few things. And thank you.
Thank you so much. That was amazing. And we definitely have some questions in the chat. Also, if you have time, you should look in the chat because you have people thanking you for what you've done for them and for being here, which is great to see. The first question I see for you is, how long after liver resection do you usually recommend to wait before a lung resection? This would be a second liver resection for me, much more minor than the first, so the surgeon is expecting an easier recovery, but it is an open resection.
Right. So just to review the recovery from liver resection. So um, the most common question is how quick can you put the patient on chemotherapy after liver resection? For open liver resection, typically wait for 2 months. For minimal invasive, typically 1 month. So it is easier to go back. Now, the recovery is easier for minimal invasive as well. So to go on to lung resection, I would say 6 weeks is enough time to go back to lung resection. We actually have a lot of patients who needs a lung resection afterwards. So we have thoracic oncology service as well. I don't do lung resection, but I have a surgeon that does lung resection. And this is obviously a part of our comprehensive cancer center. The lung resection also actually done robotically. So minimal invasive lung resection after minimal invasive liver resection. So the recovery from lung resection minimally invasively also much earlier, much easier for the patient, as long as it can be technically done safely.
Great.
Let me
Then,
let me.
oh, sorry. There's the next question. Are you ready for that one, or are you going to continue to answer that one?
Look at this. There's my patient here. Can you believe it? I remember.
You definitely remember. She's
There's my
unforgettable.
patient here. Look at
Yeah.
this. She gave me a hug. Okay, good.
So
Um,
I wanted to go to the next question, which is,
yeah.
are the guidelines for tumor size, amount of tumors, and tumor location the same for open surgery and robotic surgery?
The answer is the same. The answer is the same. Um, there have been a lot of discussion that is basically revolving around, can you take more liver if you do minimal invasive if it's open, because it's technically less stress for the body. In theory, minimal invasive resection should be able to remove more liver because less stress. But for now, we are using the same the same cutoff of having to preserve 20 or 30% of the liver behind. Now, the difference is, though, if you need a stage resection, meaning that you will need more than one resections, it is better to do minimal invasively because, as we know, every surgery in the abdomen, including the liver, it will leave scar tissues behind, scar tissues. And it is difficult to go back to do the second time, third time, if the patient were done all open. You see, because open surgery will leave a lot more scar than the minimal invasive resections. So we know that the colorectal metastasis is not a one-time deal. Many times patients have a recurrence, they need to go back, the surgeon needs to go back and do some more work. So at the beginning, giving them minimal invasive resection will preserve the window. We don't burn the bridge for the future resection. It is less problematic to do resection in the future after minimal invasive. Less problematic means it is easier for the surgeon, but also it is less chance of developing complication from the patient's perspective. There are patients that operated actually 5 times over the last 10 years or so. So we have to redo the operation every 2-3 years or so because of the new recurrence, even with chemotherapy. So it is quite common to have to redo the operation. Therefore, we believe that minimal invasive surgery is the way to go for this.
Great. This is a question on, I'm hoping to have liver transplant. I'm doing chemo in preparation. I watched another doc talk with Dr. Hernandez, who said every liver he's removed from a cancer patient for transplant came back positive with microscopic tumors. So recurrence is, going to happen. That thought alone leads me to want transplant. I don't want multiple surgeries and long-term chemo and treating whack-a-mole every time something comes up. Are there other ideas and technologies that don't use surgery? I know about histotripsy, but my Mets are in the right lobe, unfortunately. Also curious if you do transplants.
Um, this is a very loaded question. So, liver transplant has become a new. It's actually not new. When I was in Pittsburgh back in the days, liver transplant for colorectal metastasis has been tried with a poor outcome, actually. So this is not a brand new idea. This is an old idea that is brought back with the hope of improving the outcome with a tighter selection process. The issue is many times this patient they have multiple lesion in the liver, and this is what this patient actually concerned about. But you have to remember that most patients they have a systemic disease. So the idea of replacing the liver, unfortunately, it is not kind of like one-time deal, because the issue with liver transplant is many times the cancer occur in the new liver. Why? Because the bloodstream got cancer. So it is not only the liver got cancer, right? The bloodstream also got cancer. So the downside of liver transplant is the recurrence in the new liver is high. So unfortunately, it is not easy to say I'll be away from recurrence, because even the new liver will recur too. There are many other treatment that is available today. Obviously, systemic chemo is one of them. Regional chemotherapy with hepatic artery pump to try to keep the recurrence lower. The new kids in the block is called histotripsy. The issue with histotripsy is it is such a new technology, the outcome has not been studied well. I actually know very well histotripsy. At this time, it is difficult to do histotripsy in the very deep tumor behind the rib, because the energy cannot penetrate the rib. So it is still limited. In the future, I hope the technology will get better so we can reach the deep tumor. So it is a bit difficult to do on the right lobe, because right lobe is deeper. At this point, we still don't have we still not offering liver transplant. In the future, maybe. The selection criteria is strict. And actually, it is different from center to centers. And even on the same centers, they keep changing the criteria because everyone wants to select the patient, see how they do um, before transplant in order to really maximize the benefit of it, because you know you need to use an organ for this. Some program use a living donor, some program use a DCD. DCD is it's kind of like a donation after cardiac death. So this the liver is a bit marginal to use. So some centers do that in order to to be able to get the graft, because otherwise, how are you gonna get how are you going to get the graft? So I think it is something that we need to use in a very selective manner. Only about maybe 1% of patients ended up getting transplant, maybe less even. So we need to maximize all the other treatments before we use the transplant. Now, sometimes the patient go to a center and the surgical oncologist told them, you are not resectable. But if the patient go to a different surgeon who have a lot more experience, they're going to say, yes, you're resectable. So you see the definition of resectable is different from center to centers. And many times the oncologist is the one who tell the patient you are not resectable. It is actually something that needs to be it is something that needs to be done by surgeons. This is my daughter. So it is good to consult the surgeon to really know, am I resectable or am I not resectable? Because even if you go to a center that offer liver transplantation for this, they have a protocol for this, a study protocol, because this is our study protocol at this point. This is not standard. They will still first evaluate whether you're resectable or not. And if you're resectable, they're going to resect you. They're not going to give you transplant. So that is probably what I can tell for now.
Great. Another question would be, would checking for cancer outside the liver be a reason to do open versus robotic?
No, no. A tumor outside the liver, as you can see on the video, the tumor on the adrenal gland, we actually remove it robotically. Those are outside the liver, right? So the organ involvement, which organ actually does not lead to whether open or robotic. The decision to do robotic mainly depending on the number of tumors, the location of the tumor, the size of the tumor, and more importantly, the technical experience or familiarity of the team to robotic surgery. I think that's probably the most important. Used to be when I started this program in 2016, we only offer about 70% of patient robotic and 30% patient got open operation. Because at that time, we are learning how to do this. And we got no teacher back then. We are inventing this operation pretty much. Over the years, we perform many hundreds of this. So we become more confident, technically improved to be able to undertake more complex, difficult operation minimally invasively. Even the patient with Y90, which is usually very difficult to do after Y90, we are able to minimally invasive. Patient after prior operation, stomach resection, gastric resection, now it can be done minimally invasively. So our rate of robotic resection today is about 90%. So there are still 10% of patients we still do open. So it is not like a center do only one thing. You have to do everything. You have to be able to do everything, even open or even minimally invasive. It is all depend on the patient condition and the tumor condition.
Thank you. One question would be also, is there a limit to how many lesions you can remove robotically? This would be for recurrence, 5 lesions in the liver and 2 in the omentum.
So this is actually a good question, because this is a moving target. So, back in the 1980s, the recommendation was only to remove 3 lesions, only 3. So if you got 4 lesions, you're unresectable. And that probably holds true maybe about 3 years only. The guideline was changed. If you have more lesion, 5, you can resect, more than 5, no. And it probably stay for maybe another 2 years and change again. Basically, the bottom line is this: the number of tumors actually do not determine whether the patient can be resected or not. But what determines is how much liver to preserve. If you can preserve the tumor, the liver, enough, 40% or 30% for the patient to live, you resect them. So um, it is important to preserve as much liver possible, because if the patient needs a further resection, you need to have liver to work on, right? I have seen actually a colleague of mine who worked in Italy who actually resected 72 tumors at once. So you go figure that. In America, we're arguing about 10, 15 tumors. How about 72? So go figure that. Sometimes they have omental nodule, 2 or 3. Um, the guidelines is now becoming more clear about this omental lesion, because the patient with limited extrahepatic disease in the omentum, in the small bowel mesentery, they should be resected. This patient will gain survival benefit. When I was in residency, when we see a tumor, 1 dot on the omentum, we cancel the case, But it is no longer true now. If the patient have limited disease in the omentum, you scoop them out and then do the liver resection. Patient go on to systemic chemo and get observed, periodically by the oncologist. And this has improved the long-term outcome as well.
Great. I think I just see 1 or 2 more. Can you do this procedure if a patient has a non-functional HAI pump? So if they already have the pump, and then also this follow-up to that is the robotic surgery available if there are lung mets?
The answer is yes to both. Like I mentioned before, many patients, I do a robotic liver surgery to clean up the liver, and then after that, 4 to 6 weeks later, I send them to my colleague to do a robotic lung surgery. So they get robotic both. Many patients come with the HI pump as well. I actually recently operated on somebody with the non-functioning pump. I end up removing the pump actually, because it's no longer working and it's actually causing problems. So the bowel is tangled around the tubing. So I removed the tubing. So presence of pump make the operation a bit complicated, but it doesn't mean that you cannot offer the patient robotic liver surgery. You can. I think what I want to say is this. I'm happy that there's a lot of enthusiasm about liver transplantation. I do love liver transplantation, but I think at this point we have to be very cautious. We have to look at the data. The data from Norway, SICA 1, SICA 2 is promising, but the criteria is very tight. As I mentioned before, even the criteria in the United States are evolving. Used to be it's offered for everyone. Like when I was in Pittsburgh, the early days of Pittsburgh transplant service, they used to offer to a lot of people, and the outcome is bad. Why is the outcome bad? Because the selection criteria is bad. So a patient with a big tumor with the high CA, they offer transplant, and sure enough, the tumor occur in a new liver within 3 months. So if you see the criteria for this, the CA has to be less than 80, and the tumor size and yada yada yada. So people are kind of learning what is the best selection process for this, and it is very selective. in offering this. I don't want people to think like this is just like, kind of like okay, I can get it anytime and this is gonna fix the problem. No, it's not, it doesn't, because there's still things afterwards. Tumor cancer, the new liver is a new problem as well. So I hope it doesn't occur, but it does occur in your liver though.
Thank you so much. And we have one last question. This is our last question for the evening, and hopefully you don't mind. Are you able to see a CT of the liver well without using contrast?
The answer is no. So some lesions, some tumors can be seen without contrast. But if we are talking about trying to see all the tumors in the liver with this disease, having a contrast enhanced CT scan is very helpful, because the tumor can be easily highlighted when the background liver is a bit brighter. Colorectal liver metastasis is hypodense on the portal venous phase. So there is a way of looking at the CAT scan, and there is a way to differentiate tumor versus non-tumor based on the timing of contrast being perfused in the liver. The same as MRI as well. The MRI is also done with contrast. It's just a different contrast. Both are good. MRI is a bit more sensitive than CAT scan, but the CAT scan is better at looking at vasculature. So both are complementary in terms of a diagnosis. Over the years, we have issues with the patient with the contrast allergy, actually. So we develop a protocol of how to get a good quality imaging despite of having a contrast allergy. So um, sometimes it's better to get an MRI if they have a contrast allergy with the CAT scan, or vice versa. But the worst thing that can happen is the surgeon miss your tumor. So you want the surgeon to be able to see the tumor, because otherwise, after the surgery, oops, you still have tumor, by the way. So you want to have the best look during evaluation so the surgeon can do a complete job in your liver.
Oh, someone said I missed a question. So is it okay to just do one more?
Or anything, any questions?
Sure. Let me see. Oh, I see it now. Just so you know, when I scroll down the chat, it kind of bounces if someone's asking a question below. So it bounces around. So I apologize.
No.
So is it true in your experience that every liver will have microscopic tumors remaining after resection?
That's actually not true. Um, so let's put it this way, right? It is common. It is common that the patient have a micrometastasis, but it doesn't mean that all livers will have micrometastasis. I mentioned earlier at the beginning of the presentation, 20% of patient, 20% of patient actually cured with surgery alone without chemo. So think it this way, right? 20% of patient cured with surgery alone, no chemo. If all liver would have had micrometastasis, there is no way they can be cured 20%, right? If all liver have metastasis, it means they will recur at some point. So it means that 0% patient will be cured. But that fact is not true. 20% of patient will be cured without chemotherapy. So a lot of people have micrometastasis, but some people don't, because they are cured with surgery alone. We learned this on the liver resection. It is quite often that I remove half of the liver, and the pathology report came back as no viable tumor, actually. it means the patient did not need the operation because they've been treated before and there is no viable metastasis. Um, so, it all depends how reactive the tumor to the chemotherapy. Sometimes the chemotherapy wipe out the whole tumor. So it means the patient got no tumor in the liver. So I think it is all depends on the circumstance. But to say all the metastasis will leave with the micrometastasis with all liver is not true.
Well, thank you so much once again for all of your time and your attention, and also your family for sacrificing your time tonight. It was sweet to see your kids. But thanks to all the patients and families that showed up. Thanks for your attention and your great questions. And thank you, Dr. Sucandy, very much. We really appreciate this. And as I said, this will help people not just now, but in the future as we put this out on Colin Town University and refer back to it. And you had several patients here, and they said, one patient, I don't know if you saw the comment, but said, thank you, and you're our hero. That was from the Duran family.
So we are. I work in Tampa, and basically we see a lot of patients from far away. Actually, if we look at our statistic, we have about 20% of patients actually come out of state. So 80% patient come from Florida. Like I said, we have Canadian patient on the floor today, so we're going tomorrow. Um, we offer a lot of robotic liver resection, but it doesn't mean that everyone will have liver resection robotically. It's interesting to me that everyone that come to the office before I talk, they said, "Doctor, it's going to be robotic, right?" I said, "Hang on, let's look at the CAT scan first, okay? And let's actually sit down and talk about this." But a lot of patients they have it's like you order pizza, they make pizza, I think it's important to look at case by case. It's true that in our service, most of the time you'll get the liver resection robotically, but sometimes if I feel like it is better to be done open, we do it open. But the goal is to enhance the recovery with minimal invasive.
Perfect. Well, thank you so much once again. Thanks for your time and attention, and we'll see you all around Colin Town. Good night.
All right. Thank you. Thank you, everyone. Thank you. Bye bye.